All right. So, as Eric mentioned, we're going to be having a discussion today about updates in the treatment of opioid use disorder. And I have about 29 slides or so, so we should hopefully have some time for discussion. And I'd really appreciate it if people felt comfortable reaching out in the middle. If you have questions, just jumping in and asking me along the way. And we should also have some time at the end. So the objectives for this talk is for the learners to understand the role of fentanyl and other high-potency synthetic opiates in the current opiate overdose epidemic, to explain how high-potency synthetic opiates have changed treatment approaches for opioid use disorder, and also to describe recent changes that just happened a few months ago into how methadone treatment is being delivered in our country, and also be able to speak to patients about that, because there's been some pretty significant changes there. All right, so looking at the opiate epidemic in 2022, I think some potentially positive news is that from their peak, opiate prescriptions in the US have decreased by about 30 to 40% nationally. And we've seen that correlate with also an overall decreased prevalence of opiate use disorder and an increase in the last few years in people engaging with treatment in opiate use disorder. Some things that still areas to work on is that the United States remains the #1 country in the world for consumption of opioids, and we're still about, consuming about twice as much as the next industrialized country, and so there's still some more work to be done there. And even more importantly, our drug overdose rates continue to escalate, exponentially. Last year, 2021, is the first year we went over 100,000 overdose deaths. And the vast majority of these deaths included opioids, and that was a 39% increase from the previous year. And there are many causes for that increase, but really the main one is the growing use of what we're calling high-potency synthetic opiates. And at this point, fentanyl and various fentanyl analogs are the primary class that are being used, and have really kind of taken over the illicit opiate supply in our country. And so, what are these high potency synthetic opiates? So one is the high potency piece. These are compounds that are sometimes can be lethal in microgram amounts. So they're very high potent and very kind of can be dangerous in that regard. Also from a supply side or a distributor perspective, because they're so potent, you can package, kind of thousands of doses in very small packages and move them across borders and other areas. So there's a lot of an economic incentive to use these if you're a drug distributor, both from getting packages intercepted by customs, but also from a profit standpoint. These are also fully synthetic opiates. So as opposed to kind of the previous, heroin for a long time was the major illicit opiate, and heroin is not a synthetic opiate. So it involves, growing poppies and harvesting those plants and then, doing a treatment process to make heroin. These are not that. So these are fully synthetic opiates that are made from relatively low cost pharmaceutical precursors, and from a distribution standpoint, that's also advantageous. You can get pharmaceutical precursors that are pretty low cost and not illegal, and then make these in labs and not have to deal with cultivating poppies or whatnot. And when you combine these two things together, from the distributor side, these are basically incredibly profitable drugs, and from the consumer side, they can be incredibly dangerous. And one thing that's interesting that actually one of our really excellent researchers here at UCSF, Dan Ciccarone, has looked into is that a lot of these are kind of supply side dynamics. So meaning that if you actually talk to consumers of opiates, many of them will say, we actually prefer heroin. We actually prefer the feeling, the safety profile, the length of time. But because they're so incredibly profitable, it's actually the distributors that have really been pushing these substances. So a little bit more on fentanyl and fentanyl analogs. These are vials of heroin, fentanyl, and carfentanil. And these are looking at kind of the dose that for a naive person could be potentially lethal. And what you can see is once you get to the carfentanil, which is the most potent, it's a very small amount. So that's something that we kind of take into account. things to know about fentanyl and other fentanyl analogs is they're now, at this time, pretty much present throughout the illicit drug supply. So when our patients, not only our patients who are using opiates, but people who are using meth or cocaine or buying what they think is Xanax, we are finding fentanyl in all these products. And even recently, I didn't actually kind of believe it for a while, but I've seen it enough times now that even sometimes in the cannabis supply, fentanyl is being mixed in there in the illicit cannabis supply. So we are, encouraging everybody to kind of educate your patients that if they're using illicit drugs, there's a chance there might be fentanyl in it, and doing, some harm reduction counseling and testing around that. The other thing with fentanyl is that there can be what users will call hot spots, which are basically one bag is, the fentanyl is basically not mixed accordingly throughout the supply. So one bag could be more other, heroin or other products, and then one bag could be almost all fentanyl, and users don't know the potency, and that can lead to even more risk of overdose. The other thing we're seeing with fentanyl is people develop just incredibly high tolerances really quickly to this medication. And, fentanyl is active in microgram doses, but, we're treating people who are, using a gram of fentanyl a day. So it's an incredibly high opiate tolerance. And it can be very tricky trying to treat these individuals with the medications we have, like methadone and buprenorphine, because of the incredibly high tolerance. And this slide is just to show, fentanyl is not the only synthetic opioid out there. It kind of has the market now, but it is very likely over the coming years that we're just going to see more and more of these high potency synthetic opiates. Isotoniazine is something that I've seen in a few of my patients. When we send it out for specialty testing locally, that's been in their supply. That's another, highly potent synthetic opiate. And then there's increasing research chemicals that are being linked in different parts of the US to overdose. This is U47700. This other one is O-decyl-methyl tramadol, which is basically a tramadol derivative. And the point of why these are being made is that essentially the chemists can make new opiates faster than legislators can make them illegal. So there's a lot of incentives to make new opiates that are not yet illegal, so you can kind of transport them, synthesize them, and not face legal repercussions. And it's likely during our next few years, we're just going to see more and more of these. The other thing that's growing a lot that we're seeing is the use of the darknet to purchase drugs. This is a logo from the White House market, and we have, Walter White here, which is well known from the Breaking Bad show. This was the #1 darknet market until this fall, and then they actually shut themselves down voluntarily, and it's kind of unclear at this point what the next big darknet market's going to be. But if you can see on the right, these markets work, very similar to like an eBay, where you can go on and look at different drug supplies and order them. And increasingly, people are using them. The Global Drug Survey is estimating about 30% of people have, purchased drugs on the darknet, of people who are users of opiates. And these are very sophisticated marketplaces using technology because these are illegal activities, using technology to avoid detection. People use Tor browsers, which are very difficult to track what they've been viewing. They use Monero, which is a cryptocurrency that's basically is a privacy currency. It's very difficult to track, and there's actually a $650,000 bounty from the IRS for anybody that can crack this cryptocurrency, and nobody's been able to do it for years. The drugs are just delivered via your normal mail system. So the drugs show up in your house through USPS or the UPS or FedEx. And it's set up, it's very sophisticated. It's set up like e-commerce websites. So there's vendors, there's reciprocal reviews from the user and the seller about the product and how things went. There's an arbitration system if there are disputes. And I think it's important for us all just to know about this, because one of the things, that's important in working with people with substance use is we talk about kind of access to drugs, where they're getting them. And, in the past, it was really kind of trying to limit, time spent in areas that are really drug entrenched, or places where you've used or had access to drugs. But now with the ubiquity of smartphones and laptops, basically drugs are available anywhere that you have a device. And so we have to kind of think differently about how to work with people when they have access in that way. Okay, so I'm going to pause there for a minute and see if there are any questions before we about kind of the opiate epidemic, the dark net, high potency synthetic opiates, before we go on to talk about treatment. And I've learned with Zoom, you sometimes have to wait, 20 to 30 seconds to see if anybody jumps in before you move on. So I'll do that.
Hi, Dr. Hoefer. Thanks for giving this talk. In regard to the synthetics, with synthetic fentanyl or fentanyl siblings, cousins, do you have a sense of which which age demographics or populations these are particularly tied to? Is it folks who would just be younger and more savvy with purchasing on the dark net, or do you feel like this is becoming increasingly mainstream? I may have missed this if you included it earlier.
Oh, it's a great question. Yeah, so I think with the research chemicals and the more exotic opiates, it's definitely a younger demographic, a more tech savvy, maybe people who can access tech and use it. With the darknet, definitely seeing that. And then with the fentanyl, I think at this point they've said of drug, and people at DPH, if they're here, might know better than me, but I think drug seizures in San Francisco for an illicit opiate, I think it's like somewhere between 84 to 94% of those samples have fentanyl in them. So at least for fentanyl and fentanyl analogs, they're kind of mixed throughout the entire illicit drug supply, opiates mostly, but like I said earlier, we're finding it in meth, cocaine, even cannabis, sometimes Xanax pills that are pressed. So the fentanyl use is really being kind of, everybody who uses, illicit drugs is being exposed to it. And often they are not, unintentionally being exposed, and they would actually prefer to be, using something else, but it's just kind of everywhere.
Thank you.
Yeah, great question. Thanks. Any other questions? Okay, well, let's move on. So how does the increasing use of high potency synthetic opiates, how does that affect the way we think about treating people who have an opiate use disorder? So starting off with a few things that I think anybody can really do, whether you're an addiction specialist, whether you work in pediatrics or OBGYN or whatever specialty. If you have somebody who has an opiate use disorder or is using, at this point with Narcan, if they're even using cocaine or meth or other things, we're basically recommending naloxone kits to anybody using illicit drugs at this point, because it's being mixed in so many different things, and finding this a useful intervention for people. Sometimes there can be hesitancy from our patients about taking a naloxone kit. Either, the things I most commonly hear is that, I'm not going to overdose. I don't, this is not for me. And are you actually saying that I'm, a drug addict or some other, because you're giving this to me? And then the other one is people will say, well, I use alone mostly, and so if I overdose, like, I'm not going to be able to use it on myself. So how is this going to be helpful? And so we, in both of those cases, we kind of just do some education about, this is something that, you're potentially, if you did have an overdose, even an accidental one, family or friends or somebody could, use and help you with. But also, more importantly, this is something you could use for somebody else. And whether you're using with people or not, I've, walking down the streets in San Francisco, there are sometimes people overdosing, or you could really help save a life. And when you present it that way, I've had much more of my patients being willing to take the kit, and a lot of them have been using them throughout various places in our city. So, recommending this across the board. And I think the change here is not just for opiate use disorders, but because the fentanyl is in, stimulants, other things, really for anybody using illicit drugs, it's a good idea for them to have this. The other thing is really promoting fentanyl testing, wherever we can. On the left here, we have fentanyl test strips, which are dipsticks, point of care tests. They can be used either to test a urine sample, or they can be used to test an actual drug sample. Somebody can break off a piece of what they're about to use, suspend it in liquid and test it and see, hey, does this have fentanyl in it? And if it does, either decide not to use it or decide to use it in a more cautious manner to prevent an overdose. And these are available through Department of Public Health has them. And we also at the VA, we have a lot of these that we're giving out to clients. The other thing is just really encouraging people who are doing drug testing to make sure they're including fentanyl in their drug testing. We need to update our drug testing panels so they reflect what's actually being used in the community. And so using fentanyl testing, and this has been a really useful tool for us at the VA. We started this about a year ago now, and we had a lot of people who we've been, probably every week or two, I'm informing people that they're testing positive for fentanyl and they're not aware, they're not intentionally using fentanyl, and they're really, concerned by that. And that can help open a really useful clinical conversation about how to reduce harm going forward. The other thing is, I think it's useful for all of us to be, versed in discussing harm reduction type tips with our patients. This is a manual from the Harm Reduction Coalition that titled Getting Off Right, which is available on Google, which I think is really great. That can be given to patients, but also providers can read and get some more familiarity with these principles. But, the common ones that we recommend for people to prevent overdose is, trying not to use alone, using test doses, so small amounts at first till you know the potency of what you're using, making sure you have access to sterile injection supplies. And this is a link through, Department of Public Health to various needle exchanges in the community. Okay, so transitioning to opioid use disorder treatment and how it affects, how the high potency synthetic opiates affect their selection. We have 3 medications that we use to treat opioid use disorder. Extended release naltrexone, or Vivitrol is the trade name. This medication is, in my experience, really a useful tool that we have, but it's really only relevant to about 5% of our population of people with opioid use disorder, but mostly based upon patient preference. And there are 2 issues here. One is that, individuals need to be abstinent from opiates for about 7 to 10 days before they take this medication, which means going through withdrawal, and that's a very disturbing and difficult process that many people want to avoid. And second of all, this medication doesn't provide pain benefit, and there's a lot of pain issues involved with opioid use disorder. The pros of this medication is anyone can prescribe it. You don't need any special certification or clinic to do it, so it's something we can prescribers can make available. The second one is methadone, and I think methadone for hypotensive synthetic opiates is really become increasingly used because it's really easy to start. We've known for a long time that methadone has the highest retention of any of our medications for opioid use disorder, and we know from addiction research that the longer people are in treatment, the better they do. The downside of methadone is for opioid use disorder, it has to be given in an opiate treatment program. And that can sometimes have some issues with access. And then we have buprenorphine, which is compared to methadone, safer, more flexible. It can be prescribed through an office. And important thing for everybody to know is that recently there used to be you had to do a special training to prescribe this medication, but that has changed. And now you can prescribe buprenorphine. Anybody who's a prescriber can prescribe buprenorphine for up to 30 patients. And you don't need to do a training, but you do need to go on to the DEA website and apply for the X license, which is just kind of going on and doing a few clicks. So hopefully that's reducing barriers and opening up expansion of people using this medication. So buprenorphine is a good option for a number of things, but there's one tricky issue, especially with fentanyl and high potency synthetic opiates, is that buprenorphine being a partial agonist, which you can see here on the schematic on the right, it tops out at about 50% activity, which is useful because it it doesn't tend to cause people to, cause respiratory depression like other opiates. But one issue you can have is that if you give it to somebody too soon after using fentanyl or methadone or a full agonist, you can actually precipitate withdrawal, which is a very uncomfortable experience. And there's a lot of individual variability between people in this regard. Some people can use fentanyl or an opiate and take Suboxone an hour later, and they can be totally fine. And then some people wait 24 to 48 hours and they still will have a precipitated withdrawal event. And so if somebody has a history of precipitated withdrawal, we're really careful and going slower and being careful with them. And the reason that fentanyl tends to cause more precipitated withdrawal with buprenorphine and make it harder to use buprenorphine in these patients is thought to be due to the incredible lipophilicity of fentanyl and the fact that it hangs around in the body longer. And this is a recent study from Baltimore, Johns Hopkins, where they tested people, fentanyl users who came into residential treatment over the course of a month. And what they found is that, fentanyl was staying in people's urine for about 7.3 days, but norfentanyl, one of the primary metabolites, was staying in for about 14 days. And one patient still was testing positive after 26 days, which is incredibly long for opiates. And we think it's this lipophilicity and hanging around in the body that for longer that makes it so much more difficult to use buprenorphine with these clients. And so this has led to a change in, how we use buprenorphine, or we think about using buprenorphine in people with opioid use disorder. Historically, the plan with buprenorphine when, it was mostly heroin and oxycodone that people were using is that we would have them wait, 12 to 16 hours, go into withdrawal, and then we would start the buprenorphine, and that would work pretty well. What we're finding for fentanyl users is that sometimes they wait, a day or two, we give them buprenorphine, and it still makes them sick. So we're thinking about different approaches for how to kind of help people now get on buprenorphine. And a number of us who have been doing this for a while kind of miss the old days of like heroin and oxycodone, where it was much easier to help, get people started on buprenorphine. And so what that's really done is people started creating these microdosing strategies. And basically the idea is to introduce very small, instead of having somebody stop, they can continue to use fentanyl or whatever they're using. And we introduce very small levels of buprenorphine and build them up over time, usually about a period of 7 days. And when you do this correctly, people can really avoid going into withdrawal. And then by day 7, they're on a therapeutic dose of buprenorphine. And then the idea is that they can then stop whatever medication whatever substance they're using. And we actually just recently, I want to give a shout out to our addiction medicine team here at UCSF, who Dr. Suin and Dr. Soran, who just published on this on February 10th, but they just published a case series of using microdosing strategies for people with opioid use disorder in the Journal of Addiction Medicine. And there are a number of different research groups here in San Francisco, Vancouver, over the US, all over the US now, developing different protocols to try to figure out kind of what's the best way to start buprenorphine in people who are using fentanyl and other high potency synthetic opiates. This is the protocol we use at the VA, which is based upon kind of our understanding of the research and clinical experience. And the idea is, just to have this as a reference slide if people are using buprenorphine in their clinical practice, but also just to get to the idea of kind of what this microdosing looks like. Again, starting very low and slowly building up over 7 days. And these are all with the sublingual forms of the buprenorphine. We've also developed another protocol at the VA, which we've presented at conferences and published on, which is a Butrans patch protocol. So this is using, instead of sublingual buprenorphine, we're using transdermal buprenorphine patches, which are quite low doses, and using those to slowly introduce buprenorphine to the system over time and get people started in a way that doesn't cause withdrawal. Another thing to mention with buprenorphine that's kind of new and changing is that one thing we should know is that there's been, over 30 randomized controlled trials at this point, looking at various ways of trying to taper people off of this medication in a way that things go well. And pretty much every study shows that people do better if they stay on this medication. And if people come off of it, individuals with opioid use disorder, relapse rates often approach 80 to 90% within 1 year. So really the recommendation we always do as providers is to kind of stay on this medication as long as it's helpful. There's also a famous study that showed where they had people on buprenorphine and they either tapered them off of over a month or kept them on for a year. And they compared those two groups. And the basic take home was the people that were tapered off over a month, none of them were in treatment after a year, and 20% of them had died of an overdose. Whereas there were no deaths in the group where the people stayed on buprenorphine, and about 80% were still in treatment in a year. So really overall staying on the medication as long as possible is most helpful. But there are people who do really well on the medication, and for various reasons, it does make sense to come off, and we do, we've successfully done that with a number of people. And one new technique that some researchers at Colorado have published on, and we've used some in our clinic, is we've recently had access to a medication called Sublocade, which is a once-a-month buprenorphine injection. It's a subcutaneous injection in the abdomen, and it has a very long half-life. And we've actually been using it to help people who are doing stable, who are having difficulty tapering off the sublingual dose. We'll give them one injection of the depot and let that kind of wash out over the course of months, and that's actually worked quite well in helping people come off of buprenorphine when it's kind of clinically appropriate. So that's a new tool that we've been using that I wanted to share today. And I think I'll pause there. The next topic I'm going to talk about is methadone and changes to the treatment delivery system. But just wondering if anybody has any questions about buprenorphine, microdosing, Sublocade, anything buprenorphine or extended release naltrexone, Vivitrol related.
So there is a question in the chat that says, does the detection cutoff for fentanyl correlate with clinical activity? Meaning like a positive fentanyl screen, even if 7 days out, does that correlate with meaningful serum concentrations to complicate buprenorphine induction?
That is a great question. So we don't have any great data on that. So we don't have any great data where they've kind of tested that. Okay, you're still positive for fentanyl at 7 days. If we give you buprenorphine, does that change the fact that you're positive at 7 days or not? Does that change the risk of you precipitating withdrawal? We don't have any great data on that. But I think, the way I look at that study is it's just kind of indication that fentanyl hangs around much longer than other opiates. It's in the system, and that may be kind of what's causing people to have difficulties inducing buprenorphine. And I've even had it happen, I think the farthest out, I've had people precipitate 3 or 4 days out, which is not something we used to see with other opiates. And so it's really, it's different. And the only other thing that I'm thinking about clinically, which is not the same thing, but I did have, there was a patient who was given a Sublocade shot and 8 months later still had trace amounts of buprenorphine in his system. So Sublocade people can test positive for buprenorphine up to a year after their last Sublocade shot. And so that person had I forget what it was barely detectable levels of buprenorphine, and was in residential drug treatment, and they were trying to switch him on to Vivitrol. And so they gave him like a very small dose of naltrexone, like 5 milligrams. And he had a robust precipitated withdrawal syndrome. And so again, we're not talking about fentanyl here, but even, at least from that perspective, very low dose buprenorphine and naltrexone, there was a withdrawal response. So I think it remains to be seen, and it's a really great question that we need to look into.
And then Josie has her hand up.
Okay, please.
Hi, I have 2 questions. Well, the first is when you're doing the microdosing algorithm, you adjust the doses of the adjunctive medications you use for symptoms, such as the hydroxyzine and the clonidine and Zofran that they, for withdrawal symptoms. Do you use lower doses or higher doses, or are those adjusted at all? And then my second question was, I've seen in the literature, the argument for explaining to patients that the journey to being tapered off of off of bup or methadone is a long one and usually doesn't happen until like years later for success to be successfully tapered off. However, what's your response when patients, especially from marginalized communities, say that the reason that us physicians are keeping them on is, for the pharmaceutical industry because we're getting paid by them or whatnot?
Great questions. Yeah. So I'll start with the second one. Basically what I say to patients is, I try to say that I recommend you stay on this medication for at least a year. And that, because that correlates with some information we have about, basically the idea is that the brain, does recover over time from substance use, but it takes time. And a lot of the data we show is kind of stress systems, depression, mood systems, sleep systems. Those tend to kind of re-normalize after about a year or two. So I recommend, that people stay on for at least a year, and then we kind of talk about it. If they really can't, if that's like not even tolerable, then I say, okay, 6 months, and then we try to, and then at that point we try to work on kind of, just decisional balance stuff about like, is this medication may be helping you with addiction, it may be helping you with pain, it may be helping you with mood. Is it a net positive in your life? And for the specific question about, pharmaceutical, paying me or trying to keep people on it, I just try to say that, and maybe I can say this at the VA, but I think someone said that I don't actually receive any benefits from the pharmaceutical industry from this. This is a generic medication. And, I'm just trying to give you advice based upon the best kind of my clinical experience and the research I have about the way addiction works and what we know about how these medications can be helpful. But it's ultimately, and then in a very MI consistent way, but it's ultimately your decision, whether you want to remain on these medications. And I'll work with you whether you do or not. And I think by emphasizing their autonomy and ultimate responsibility for their health, I think that can help you get out of some of the control dynamics that can come up around it. And then I think that for the first question, when we're doing these microdosing protocols, we do use symptomatic meds, and I don't necessarily tend to adjust the meds, although I am kind of saying if you are using Suboxone, with the microdosing, hopefully that will help a lot with the withdrawal. But if it doesn't, we can give you these meds. And what I tend to do, what I find works best, because sometimes if you give people like 5 meds, they don't know what to do with them. And they're like, what is this? I tend to ask people, what is the 1 or 2 symptoms of opiate withdrawal that are the worst for you? And I try to target those. And I try to give people like a 5-day supply of that, of 1 or 2 medications. And often those tend to be, clonidine, Zofran, loperamide, or I actually like to use mirtazapine for people with sleep issues. And this because mirtazapine not only helps with sleep really well during opiate withdrawal, but it also has a built-in 5-HT3 antagonism. So it has a built-in Zofran-like effect. So it also causes the stomach. So you calms the stomach. So you get a 2-for-1 there of both helping with sleep and nausea, and people tend to tolerate it pretty well. And that's how I approach kind of symptomatic meds during microdosing inductions. Thanks for the questions. All right, I'll press on. So, talking a little bit about methadone. This is a picture of our methadone clinic at the San Francisco VA. And I have the tumbleweeds here just to kind of show that how much methadone has changed during COVID. This clinic used to be, filled with chairs, and there was, a line and people sitting around talking and groups going on. And it was a very lively social clinic. And during COVID, that has very much changed. And a lot of our opiate treatment programs across the country that have to try to, take precautions to reduce the risk of COVID. But one of the things that's come out of this is, methadone has now been around for decades and has had a very kind of strict guidelines about how often somebody has to come to a clinic and to get take-homes of the medication. And in some ways, it's really been kind of a barrier to people accessing treatment. So you have to go to an opiate treatment program, which some states don't even have a single opiate treatment program. So there's access issues there. Second of all, people, starting off would have to go to the clinic 7 days a week or 6 days a week for 90 days. And then after 90 days, they could get one more take home. So then you're going 6 days a week for 90 days. And really, if you did everything right, showed up, went to, all the drug screens looked good, saw your counselor, was doing well, you would have to go for 2 years until you could get a 28-day supply of this medication. And so that can really limit, how much somebody can engage with childcare, with a job, with other things in life that we want people doing. And this has been fixed for decades, and really it's been taken kind of out of physicians or clinicians' hands about, how we can prescribe this medication, how we can kind of meet patients where they're at and try to use it flexibly. We just kind of had to follow this algorithm. And so if there's anything that's a potential silver lining to COVID, is that has dramatically shifted during COVID. So for the first time, I believe ever in the decades of methadone treatment, this is in March of 2020, due to COVID, SAMHSA and DEA sent out a guidance that effective immediately, patients who are stable in an OTP clinic, which is left up to the medical director to decide, can have 28 days of take homes. So now instead of waiting 2 years, someone could be in treatment for a month. And if they're doing well, they can have 28 days supply of take homes. And then even more kind of radical from a methadone perspective is patients who are less stable, quote unquote, can have up to 14 days of supply of medications. So these are people that maybe are having difficulty coming to the clinics or have psychiatric stability issues or are using other substances, can have 14 days supply. So this has radically changed the way methadone has been delivered in our country since, March of 2020. I will say it's been, different clinics have kind of used this guidance differently. So, and there are unfortunately some profit incentives to have people when you have a for-profit methadone clinic to come in regularly. So some clinics have not embraced this new thing, but at least at our clinic and general and a lot of places that are more kind of academic or DPH funded, we have really been giving a lot more take homes, and it's really been amazing to see the difference. As far as I've had a lot of patients who wanted to start methadone or used to be on methadone, wanted to come back but just couldn't do the 7 days a week, and they've re-engaged with us with this more flexibility. And just even more recently in November, what SAMHSA has now said is that until the COVID public health emergency is done, we'll continue with this protocol above. But then after the COVID public health emergency is gone, we're going to institute for a year this new protocol, which is slightly more strict, but still much less strict than it used to be. And so this would be stable patients can get 28 days of take homes. And I won't read all these, but essentially if you're doing well in treatment for 60 days, you can get 28 days of take homes, where it used to be 2 years. So that's a dramatic difference in flexibility there. And for the less stable patients, who they're calling less stable, they can get 14 days of take homes after 30 days. Whereas these patients in the past would be essentially coming to clinic 6 or 7 days a week indefinitely. And there are people who've done that for years or decades, really. So this is really a different treatment delivery system. And as you can imagine, we're getting more and more research coming out looking at, with relaxing all of these take-home requirements for methadone, have we seen an uptick in diversion or substance use or overdose? And, we're still getting a lot of this data, but most of what I've read and also analyzing the data from my clinic and also speaking to my colleagues at San Francisco General, we have not seen a large increase in diversion. We have not seen there are no significant differences in our urine drug screen results. And we haven't seen a lot of bad outcomes from giving people more take homes. If anything, my experience is I've seen more people engaging with the clinic. So the preliminary research, it's not all in yet, looks promising. And I'd encourage people who are interested in learning about this, checking out some of these different articles I've cited here. The one that's especially interesting is the one from David Frank at NYU, who is actually a PhD scientist at NYU who also has an opiate use disorder and is on methadone. And he writes really eloquently about what it's been like for him being on methadone, trying to navigate getting a PhD and being an academic and having to go to a clinic, you know, all the time, and really beautifully writes about how the impact of, you know, some of these requirements for methadone delivery that we've had for a long time. All right, so to summarize, you know, take home points from this talk, I would say, number one, you know, things that we all can do to help individuals with opioid use disorder or people using other substances really at this point is we can all prescribe naloxone and talk about overdose education and naloxone distribution. We can facilitate fentanyl testing either in our clinics or connecting people with DPH and other places where they can get these testing. Connecting individuals with needles and other safe injection supplies is very helpful for preventing the spread of infectious diseases, abscesses, things like that. And we can all provide basic harm reduction tips to our patients. Another take-home point is all prescribers can prescribe extended release naltrexone. You know, and if there are questions about, you know, how to do so, I'm always available. Our addiction medicine, addiction psychiatrists are always available to people to help you walk through that process. And now buprenorphine is more available to prescribers than ever before. If you want to treat 30 patients or less, all you have to do is go on, you don't have to do any special trainings or anything. You just go on the DA website, click a few buttons, get a DAX license, and then you can prescribe buprenorphine. And if you want to do over 30 patients, then you have to do the special trainings. But this is, you know, again, we're dramatically trying to reduce barriers to people providing these medications because we have nowhere near the amount of addiction specialists we need to treat the millions of people with opioid use disorders. The other take-home points is that microdosing protocols are becoming the standard of treatment for people using fentanyl and other high-potency synthetic opiates to minimize precipitated withdrawal. And we're getting, you know, more and more research coming out about that. And we have some really excellent researchers here at UCSF working on these problems. And then finally, I think we all should be able to speak to our patients about how methadone treatment has really changed recently, both in flexibility, accessibility, and methadone with fentanyl and other things is, you know, the easiest medication to start at this point. And so I think really being able to talk to patients about that and, you know, correct any misconceptions they may have about the way methadone is delivered in this country, it's really changed, and we might be able to get some more people to be willing to engage with it. And this is more of a schematic of what I'm talking about here about, you know, treatment options for opioid use disorder. You know, 95% of the time you're trying to choose basically between Suboxone or methadone. We talked about Vivitrol, which I have up in the corner in a little box, which is kind of the 5% people that it's a really good option, but again, it's not for many people because you have to go 7 to 10 days without an opiate and it doesn't help with pain. For years, the pendulum had been kind of moving towards buprenorphine because it's safer, it's more flexible, more easy, you know, office-based. But the pendulum is really kind of swinging back more towards the middle, but more for methadone as well now because methadone is getting easier to access, more flexible. And it's very easy to start in people who are using fentanyl, where there's some difficulties with the precipitated withdrawal with buprenorphine. And with that, that is the end of my prepared slides. And we have a few minutes for questions, I think, if people have any.
That was great. Thank you so much. I
Sure.
will open it to the floor for folks to ask questions. Maybe while folks are thinking about questions, one question I have, which is, you know, if people decide, okay, I'm going to go ahead and get approval to prescribe buprenorphine, maybe less than 30 patients, at what point should we then reach out to an addiction specialist to help us? You know, when should we consult you?
Yeah, absolutely. So I think, you know, my advice would be if you've never prescribed buprenorphine before, I think I would reach out to myself, to any of our addiction. We have 7 addiction psychiatrists now at the VA. You can reach out to me. We also have excellent addiction medicine colleagues that I'm sure you all are aware of, Scott Steiger, Paul Lum, Soraya Azari, but yeah, reach out to us and just say, hey, I'm interested in prescribing buprenorphine. We can talk through the case. We can kind of walk you through it. And then my experience, having done that with a lot of people, is after about 1 or 2 cases, people really feel comfortable. It's actually a very easy medication once you get it started. And then once you see how much it radically improves somebody's life, people become really, it's really rewarding to provide this to people. And so then people take it from there. So that would be my advice. If it's your first time, reach out to us. We'll help kind of consult and help with the case. And then again, if you ever in the future get anything tricky comes up or you don't necessarily know what to do, just reach out. And we're always happy to consult and walk through things with providers.
That's super helpful. And then Cynthia has put in the chat, do you think methadone access will ever expand beyond specialty programs to other health settings? I know that would be a big policy shift, but so what do you think?
Yeah, so it's an interesting, I hope so. It would be a big policy shift, but I think things are moving in that direction. I mean, the reality is we have an incredible opiate use epidemic in this country, and we need more access to care, and still only 10 to 15% of people with opiate use disorder are getting treatment. So I think there's more, I think people are being more open and flexible about this. And I think one model that I really like is the Canadian delivery model, where they actually, individuals in private practice or, in an office can prescribe the methadone. And then people, instead of going to a specialty opiate treatment program, they actually just go to their regular pharmacy. They go to like Walgreens or CVS or whatever, and they can get methadone. And then they can also, I believe, get take homes more rapidly. And it's more based upon the doctors and the patient's, relationship and understanding than kind of an algorithm. So I think that would be a really great shift if we could get that going in this country. Because I think there's a lot of benefits to having it out of the opiate treatment program. And you can look at places like France, where it's been available through primary care for decades. You can walk into primary care, and do you want bupe? Do you want methadone? You can get it there, and they've had some really great benefits from it.
It's really terrific. Thank you so much. I know we're at time. Really appreciate all of your insight into this wonderful talk. So thank you so much.
All right. Thanks for having me. Have a great rest of the day.
You too.